you a question about what you're going to be tested on. And the stuff that I write on the board, you're definitely going to be tested on. So that's, even though the preparation piece for some of the stuff that's on your PowerPoints is because you have to know the underlying of why things are happening with patients. So that ABO type, there's a whole section in there that talks about ABO typing and blood typing, because that's what you have to do, and why it's one of those things that patients have problems with, unfortunately, is that it remains one of the top 10 med errors. So I go through the whole thing to show you about how things are supposed to be done in there. So that's what that whole thing is about, and talking about why it's important that the patient receives the right blood, because then they have other problems with that. Your thing is going to focus on what you see up here. So we talked about acute blood loss, hypovolemia, so managing patients who have, how you can tell whether or not they're shocking, giving them blood products if they need it, plasma expanders, fluids, that's what you got to know. For your leukemias, you got to know, we talked about the ones you needed to know. So ALL was the only one you didn't need to know, because that's the pediatric one. Even though it does happen in adults, it by far happens more in children. So you needed to know acute myelocytic leukemia, chronic myelocytic leukemia, and chronic lymphocytic leukemia. Those are the ones you get to know. With the neutropenia or low white count, it's just, I put up there absolute and relative, because I told you people look at that. Your thing overall is thinking about anybody who has a low white count. Because when they say absolute, patient has none. That's all they're saying is they have none, but they still can't fight infection whether they have a little bit or none. So that's what you got to think about, the whole process of care that's happening with the patient. And then I just listed the types of thrombocytopenias that happen with your patient. The ones that you got to think about is what is happening to the patient because they have it. That's the person at risk for bleeding, so those are the kind of things you're going to do to take care of the patient. The types up here just kind of tell you most of the patients have it as an acquired problem, meaning it happened because I did some type of treatment on them, that kind of thing. So that's why I listed the kinds there so you can see what they are. The idiopathic ones or autoimmunes are the ones that patient, we don't know why they happen. The patient starts to attack their own platelets. So treatment is a little different based on what's going on with the patient, but overall, it's a safety issue because the patient can bleed out. And all this stuff down here is a lot of tests, because in hematology, everything is around blood tests. Do you have to know every blood test there is? No. I'm just telling you, these are the things that they use that they're going to monitor for the patient. RBCs take 120 days to replace. White blood cells live from minutes to hours, so they can change different times based on what's happening with the patient. Platelets, 5 to 7 days. In your head, you're thinking about if the patient has a problem in either of those, how fast it's going to take to turn over and resolve. Platelets would be the quickest, because they're the ones that you can either give the patient or the process is going to stop. When you're talking about RBCs, they take longer to replenish, so that's the longer one. When you're talking about white count, because they go all over the place and based on what the person is having, that's a totally different process. And you don't necessarily give granulocytes to people just because. That's usually patients who are very, very sick that you're going to give those things to. So that's how you look at what you're studying. Think about this major disease process. How do you tell? And if you read them, I told you last week, everything will sound just alike in hematology. When you listen, when you read the information about the patient, they all have fatigue and weakness. They all have, some patients have different things based on what the other pathology piece is going along with that. But you saw lymphadenopathy and leukemia, Hodgkin's disease, it's all together. So they're going to sound alike. Focus on what makes them a little bit different as far as what you see in your patients. So some things have a better cure rate. That's what you're going to see with a patient who has Hodgkin's disease versus Hodgkin's lymphoma. So the question may focus on that. Diagnostically wise, when a patient has Hodgkin's disease, even though you think, oh, you did a biopsy on this lymph node, people go into all kinds of testing, and the patient may have questions about why are you doing a chest x-ray, why are you doing a pelvic x-ray, and it's because they're trying to figure out staging. That's where the patient teaching piece goes along with that. Pretty much in all the things that have to do with hematology on the cancer side, patient will always need chemotherapy or radiation or both. What do you do for the patient who's having those things? That's how you look at that hematology stuff. Everything when you read is going to sound exactly alike. So there's a little bit that makes it different. That box that I talked about with the leukemias, talking about the cell types and what you see in the patient will help you decipher what type of patient it is. That Philadelphia chromosome, because that happens in one of those, all right? that's something that makes it different. So that's what you look at. When you talk about Hodgkin's disease, read Sternberg cell, makes it different. So that all, you know, when you read them together, they're going to all sound alike. What you have to do is there's something in them that always makes them different from the other one. And that's kind of how you have to focus on it. Because if you look at it, all the treatments are the same. They're not any, not exactly, but you know what I mean. That's the thing that you're going to do. Look at that section about chemotherapy. Because chemotherapy, when you're inducing a patient or when you're getting it under control, or what designates remission, because that fits not only for the leukemias but also for Hodgkin's, but would be the same for pancreatic cancer, would be the same for gastric cancer. You're still trying to achieve the same thing, just a different disease process you're treating with the patient. Don't sit and think about they're all separate things. Yeah, they are different diseases, but the overall care you give to the patients in this stuff is the same. You just have to, there's little nuances that make it a little bit different. But pretty much their treatments and things are going to be the same. Okay, so don't get all caught up in it. We put out the stuff there so that you know the background of why you're doing what you're doing. Because that's the part that changes, especially when you're going from the role that you're going in now. You're trying to get all the reasons why you do what you do. You're trying to figure out and then when that helps you, when you got a person, because you know every person never fits this category you see in the textbook, right? They come in and you're sitting there saying, well, I think they have this and I think they have that. So I'm telling you, when you go back to school again, she's already planning, so I'm just messing with her now. But when you go back, that's always one of the things they do is you talk about differential diagnosis. What else does you think the patient has? Even though they present with these signs and symptoms that kind of scream out that they have something, what could be the other things that happen? So those are the kind of things now that you're thinking about. What are the other things you need to do for the patient? And always when you're looking at your test questions, when they ask different things that they're asking about up here, that you get on your test, always think about something that you do first requires either an assessment that goes with it of some type, because you're trying to figure out what the patient has. You know, you need to see what the problem is. You cannot do anything without doing some type of assessment first. Okay? Priority, when they're telling you which patient do you see first. You have people doing all kinds of things that may be happening in those questions, and all patients need to be seen. But always remember, first patient means the person that's the worst off. Even though it may sound like, oh, they're so close together, there is something in that question that will indicate that this is the worst patient. So you got to kind of look at those particular things happening in there. The other thing is, if you have delegation questions, always think about scope of practice. Even though all of y'all work and do all different kinds of things and a lot more things than a basic LPN can do, because that's what you do in your job. Forget about what you do in your job. That's what kills you on a test. Because in NCLEX world, LPNs can only give medications, do dressing changes, Foley catheters, enteral feedings. You know that's only a portion of your life. Okay? But that's how it is. NCLEX world sees anything that has to do with an IV as an RN function. How many of you do IVs on your patients? You know, so that's what I'm saying. If you're doing those things and thinking about what you do in practice, that's not what you're going to see on an NCLEX question. There are always going to be things, they look at very narrow scopes of practice as far as things that happen with your patient. So you know in this particular section we deal with blood TPN, so you know those are going to be RN functions, regardless. Even though you may give blood at your facilities where you work, it's only going to be an RN function on test questions. Okay? Starting the IV is only going to be an RN function in test questions. Okay? Because you know with the blood product you may have to start an IV. You may have to start an IV in the middle of it because the patient's IV infiltrated while you're giving the blood product. You may have to start a new IV because the patient had a reaction to something and now we can't get anything to go through the old ones. Those are all things that will be RN function. The assessment of the patient will always be you. Anything that's nursing process is always RN function. So that's assessment, planning, implementation, evaluation. You can send people to do things, but it cannot be something that requires a secondary evaluation. So if somebody's doing badly, go in the question. Right? It's not about sending somebody else to do things for you. Because in the NCLEX world, that's saying that they're talking about the delegation piece and that you understand that those things you can't give off to somebody. Okay. So in our hematology section, we had things that happen with RBCs. and that was the blood loss, acute blood loss, those types of things. Then we had the white blood cells, which were leukemia. Then we have the lymph system, that's the lymphomas that kind of fit in that part. And we had multiple myeloma, which was the plasma tissue cell thing that goes wrong with bone kind of thing. And then we had our platelets. So overall, that's how you have to think about what those cell types do, and then you can figure out what happens with your patient because of it. So that's how you have to think about those particular things. So going back to acute blood loss, we're going back over the stuff we did last week, and quickly, because after the test, y'all ain't even thinking about life, kind of thing. All right, so we had a patient who's getting acute blood loss, can be from a lot of different reasons, but a lot of times we see it in relationship to traumas. We also see it in relationship to GI disorders, because we talked about that. Patient might have a ulcer that perforates and then they start bleeding. So you just see that this patient's going to have acute blood loss that's happening. Okay. Now the thing about it is acute tells you when it happens. It's acute onset of things happening with your patient. Does not register right away that it's gone. If you look at lab work, that's going to take a while. But you can see that the blood loss is there. Generally, you're going to see a patient who's symptomatic when you have about 500 to 600 cc's of blood loss. So that's why patients can go around all the time and just be tired all the time, all that kind of thing, and not really having any overt symptoms until later. Okay, so that's what you're seeing in the patient. So based on that, when you have acute blood loss, you pretty much know I got to put some back. But in the interim, you want to try to make sure that patient is stable, so you're going to give them IV fluids. So the things that we use to maintain blood pressure are going to be lactated ringers or normal saline. Because those are the volume things we can give to the patient. Isotonic fluids is what you want to give to this patient. Now we can type across the patient, but that takes time. If it's an acute blood loss and the patient is continuing to hemorrhage, that's the person who's going to get whole blood or O negative, because those things are considered the universal donor. Okay, so what I'm trying to do now is save you at the point right now. I'm not really worried about whether or not you have an issue with ABO. Okay, but you're going to get O neg because that's considered the universal donor. Find out why the patient is bleeding, because we got to figure out why that blood is coming from somewhere. If it requires that the patient have surgical repair, then we do that. And because that's usually what you're going to have to do in that regard, or cut something off one. Because if they're bleeding like that, sometimes you got to take off an extremity to get rid of the problem that the patient has as well. But if you are not in that hurry to do things with patients when you're talking about blood loss, and that you have a patient actually threw up, and so now I said you're going to be in the hospital, we kind of stabilize you here, now I want to transfuse you because your hemoglobin is 6. Okay? Real low. All right? I'm not going to ask you every single lab value, but you should know that 6 is low. Okay? You want people, for guys and girls, about 10 to 14, that covers men and women. That 10 is still low, but people don't usually need anything. So that's why you think about it that way. Okay? So I'm going to type across this patient. Doctor's going to write an order that the patient has to give blood, and he has to explain the benefits, the risks, and the patient has to agree to do it. All that needs to be in the progress notes. Then he's going to say, type across the patient for 4 units, transfuse 2 now. Okay. Patient needs to sign a consent for the blood transfusion, separate. Way back when you signed that consent for treatment in a hospital, that used to cover blood products. It no longer does that. It has to be a separate consent that is signed. Make sure that you have a good IV, because it's going to take a little while. Usually if your patient never had a problem, no crazy antibodies, blood is usually tightened across within 2 hours. So you got a little while to get stuff done, but you want to make sure you go start your good IV site. Number 20, number 18, if you can get it in. 18 is huge, but if you can get it in, it's going to make your blood go in without a problem in the patient. Okay. So have the patient sign the consent. Take vital signs before you go pick up the blood. Make sure all of your other people are quiet and not bothering you. Okay, so you have some time to spend in the patient room. When somebody goes to pick up the blood product, you can actually hang your tubing that you're going to need, because it's 2 different. It's on a Y connector, so one side you hang normal saline, have that going at KBO rate. Get the blood product, you need a second nurse in the room. Make sure both of you identify the patient. So once you do that, identify the patient, then both of you are going to read the blood product. Okay, so while one person is saying this is O negative, unit number is so and so, expires so and so, and the other person is saying, yes, this is what I see on this. Both of you, there's a piece of paper that both of you have to sign that says you verified that information. Then you can start your blood on the patient. Start it at about 50 an hour. Stay in the room for that first 15 minutes, just observing the patient. And like I said, I never tell them everything that can go wrong. I just stand there and tell them, let me know if anything starts to feel different. And they'll say, well, what? I say, you'll know if it happens, just let me know. The usual thing they're going to tell you is it feels cold. And that's true because it just came out of the refrigerator, so that's okay. All right. After that first 15 minutes, take your set of vitals on the patient, and then you can increase your flow rate. Blood generally has anywhere about 300 to 350, sometimes 400 cc's per bag. And so in your head, thinking about how fast you're going to run it, nobody ever says, a doctor never says give it over 2 hours or 3 hours or whatever. You have to make that decision based on what's going on with your patient. The older the patient, the longer I would go. Up to, you can do the max 4 hours in that one tubing. I got a young, healthy person, I'm giving my blood in 2 hours. Okay, so somebody your age, I just hang it in 2 hours and let it be infused. Because you usually don't have a problem. There was a person that asked me when I was at a review last week, not this past week, but the last week, that they had a question and it said to run it at 75 an hour. And the nurse and the student wanted to know, well, who picks that out? I said, I don't know who picked that out. I said, but generally if they're telling it, but the question actually said 300 cc's, so that's why they said 75 an hour, but the person in the question was older. That's why the blood was running at 75 an hour. There are some things that kind of give it away. If an elderly person, because they tend to have comorbid conditions, kidney problems, heart problems, which make it problematic to give them blood products, that's why. So the slower you infuse it, the less likelihood you are to put them in acute pulmonary edema. That's what you're trying not to do. And that's why I said sometimes doctors will actually order Lasix to be given in between those units because I need the cells, but I don't need the volume. So you'll see that sometimes written, especially for elderly people. But in your head, in test questions, think about anybody who has heart problems, kidney problems is going to be my person at risk for getting transfusions because they can't get rid of the volume right away. So that's the person you worry about putting into pulmonary edema. And why you would question if a doctor's given a patient a blood transfusion and their hemoglobin is 10. It's not indicated. Okay, so if you had, that's one of those other things they can ask you in a NCLEX type question. I'm talking about they, me. I can ask you an NCLEX type question. So anything at 10, I would question that because that's not something we normally do. Okay, that's not the hemoglobin that you would transfuse a patient. So you're going to do your protocol as far as your vital signs go for your patient. Most places are every 15 minutes times 4, and then every 30 minutes times 2, and then every hour if you're letting the blood run longer than that. So those would be the things you do for your transfusion. Make sure that after it's over, you're also going to do a set of vitals on the patient. But during the time you're in the room, you're monitoring the patient for signs and symptoms of the reaction. So if they have fever, if they have anaphylaxis, if they have back pain, those are kind of things you're looking for the patient having a problem. So the reactions I told you had to look at were febrile, anaphylaxis, and hemolytic. So those were the things you need to be able to look at if you had a question about a patient receiving a transfusion that you see that that's having a problem. So febrile is going to be a temp. Anaphylaxis is respiratory distress, cardiac arrest kind of thing. And then your hemolytic reaction patient complains of back pain and their urine will turn red, essentially is what's going on with them. So if that's the reaction, all the blood goes back to the blood bank. If it's a hemolytic reaction, you also draw a blood specimen and do a urine specimen that needs to go to the lab. Okay. But that's the major thing when you're talking about the RBCs, because that's what you have in this section. All the other stuff that we had in RBCs, you had in NP2. Because you had patients who had anemia, you had polycythemia, too many cells. If you have a patient who has some type of hemolytic disorder, then you look for jaundice. Because that can sometimes happen with the leukemias. Patients can also have jaundice. So that's just thinking about what you see with your RBCs. When you talk about patients who have problems with their platelets, that's thrombocytopenia. So you have too few platelet cells. So that's going to be a person at risk for bleeding. And they can bleed from every orifice they have and every body part that they have, kind of thing. So usually don't have spontaneous bleeding until platelets are below 60. So that means somebody can be sitting up talking to you and they have a trickle of blood coming out of their nose, out of their ear, whatever. So platelet disorders, you know you got to put, the safety is the major thing you have to do. So no razors, no toothbrushes, they get the soft bristle things going on. If you see changes in mentation, you're going like, what does that have to do with a patient who has a platelet problem? They could be bleeding in their head. So the mentation issue is coming from like the patient having a hemorrhagic stroke. So those are things you're looking for with those particular patients. Look for bruising, and the bruising sometimes is going to be faint, meaning that you see little petechiae all over, all the way up to a person who has ecchymosis that covers a whole body part or a whole extremity kind of thing. And little trauma causes big time bruising. Because we all know sometimes you might stub a toe and maybe the end of your toe is discolored. These people stub a toe and the whole foot might be purple. Because that's what you're looking for with a patient who has platelet disorders. The good thing about most of them is that they're self-limiting, meaning if I get rid of the cause, it stops. And then I know they're going to replace within a week as far as the time that platelets live, so I know that it's going to be finished. Sometimes I will have to give platelets to the patient. Sometimes you have to give cryoprecipitate. It just depends on how bad the bleeding disorder the patient has is or how actively they are bleeding at the time you take care of them. If it's idiopathic in nature, that person gets steroids, because most of those patients are the ones that have the autoimmune type. So that's the person you may have to give steroids to, and then they may have to have their spleen removed, because that's the problem. It's your body is attacking your own platelets. If you have it in relationship to medications, those types of things, once we get rid of it, that's usually, it goes away and we don't have that issue anymore. Now the WBCs were probably the part that got you, because all of the diseases in that sound the same. Because when you talk about leukemia patients, they'll tell you about, oh my gosh, they all have lymphadenopathy to some degree. They all have WBC counts that are really high, some can be lower, some can be normal. They have platelet counts that are low, hemoglobin that are low. The basic thing about leukemia is, remember, it's a proliferation of abnormal cells within the bone marrow. So patients are going to have some degree of something happening with every cell type. Okay? If all the types are low, then that's pancytopenia. Everything is low. Panoramic view, cells, and penia means low. So that's when you see, when you look at our pancytopenia, all cell types are decreased. But with leukemia, you can have people have really high white counts. And that's the thing. It kind of goes all over the place as far as the white count goes. But just think about onset of symptoms. Acute is going to be sudden onset symptom that this person has, and also that the cell types are immature. That you'll see that in the box. They talk about immature cells being there. When a patient has chronic leukemia, you're talking about a patient who has slow, insidious onset that you put off to other things. You don't know what it is until you finally do some lab work and see that you have this, and then the cells are mature. Okay, so they look like they're supposed to. So those are things that kind of give it away. And then we talk about the type of leukemia that patients have. Myelogenous leukemias have the poorest outcomes. And we're talking about things happening with your patient. Okay, so those kind of things you're going to see. And then that box will tell you, some patients have a lot of lymphadenopathy, some have not so much. But the general thing whenever a patient has leukemia is that you're going to try to figure out which type they have. So bone marrow, aspiration, and biopsy are going to be done. We identify the cell type that you have, see what it's responsive to, and then you're going to start as far as your chemotherapy regimens go. It's always based on biopsy. So I can figure out what exactly the patient has. What is this tumor marker telling me when I'm looking at this patient, which is going to be the most effective drug? That's how they figure out which chemo drugs you go on. So for you, it's not so much in knowing every chemo drug, it's just that what the chemo drugs do. They kill off the cancer. So that's what you want them to do. But in essence, when they're doing that, they kill off everything in your body that has a fast growth rate. So your hair falls out because you get hair every day. Even if your hair is not long, you're still growing out hair every day. Okay. They talk about that because my brother says that when he shaves, because my brother shaves his head. And so he was talking about it. He said, yeah, I wish I didn't have to do that every day. I said, yeah, but hair grows every day. That's why you have to do it. So that's one of those things. You look at anything that has a fast turnover, it's going to be a casualty of doing chemotherapy. GI cells, parietal cells within your GI tract, that's why they have so much nausea and vomiting associated with chemo. But there are some patients who never have any. So we don't know why that works for them, but we got to figure out what helps them with that. So chemotherapy is to get total remission, meaning I don't see any signs of disease in bone marrow or anywhere else within the body. That's what you try to do, is get complete remission when you give chemotherapy. So there's different stages that they look in there. And induction, intensification, maintenance, I would look at those because that might be extra credit issues. I'm just saying. All right? So those are things that you want to look for, because that's what we do as far as treating the patients. So when you're treating them, they become, yes, they're sick and they feel bad, but it's all about safety. Because they cannot fight infection. They don't have platelets. Okay? They don't have WBC. So think about what you're seeing with these patients. Remember, bone marrow has been taken over now. Person doesn't have those to fight with. So that's why they're tired all the time. That's why they're pale. That's why they have bruising. All the things, think about what the cell types do, and it leads back to that. But like I said, when you read them, they all sound alike. There's going to be something that makes them a little different. Philadelphia chromosome is one. Bence-Jones is one because that goes for multiple myeloma. Understanding Reed-Sternberg cells, because those are things that make them a little bit different. And if you have a patient who has, if they do bone marrow transplant, because sometimes they do, you know, that's part of treatment for some types of leukemia. It's not for every type of leukemia, believe it or not. Most people think everybody can be treated that way, but not everybody can. If they're going to be doing a bone marrow transplant, they have to wait till the chemotherapy clears your body totally. Otherwise, the chemo would attack your bone marrow, what they put in. So patients have to be totally cleared of medications, and then once that is done, they can actually have the transplant. They also, it's contraindicated for you to give anything to a patient that stimulates bone marrow. So you would question the order for Epigen on a patient who has leukemia, because all you're going to do is stimulate abnormal cells growing. You know it, you just make yourself crazy.
Yes. Those questions make me crazy.